Welcome, everyone. My name is Quinton Dealey. I'd like to welcome you to the Maudsley Philosophy Group. Today we have Chloe Saunders speaking, Dr. Chloe Saunders. So Chloe is somebody with very active engagement with philosophy and its application to medicine and psychiatry. Bit of background about Chloe. She completed her MSc Psych membership at the Royal College of Psychiatry as a core trainee at SLAM fairly recently in 2021. And she's currently reading for a PhD in functional disorders at the University of Aarhus in Denmark. Her interest in philosophy started as an undergraduate at Oxford University, where she took an extracurricular course in philosophy of science and developed through her involvement with the Maudsley Philosophy Reading Group, a kind of deeper interest and engagement with the subject. So that's just by way of a brief introduction to Chloe. So thank you very much for speaking to us today, Chloe, about this important topic of the relationship between diagnosis and identity. So without further ado, I will hand over to you. Thank you. Oh, and just before we start, just to remind everybody, we normally present for about 45 minutes, and there's about 45 minutes of discussion as well. And so, and I'll be chairing the discussion, but we'd be really interested to hear people's thoughts and reflections on what we're going to talk about today, what Chloe's talking about. So thank you.
Great. So yeah, thank you, Quinton, for that introduction. And I'm going to share my slideshow here. So I'll assume that you can all see my slides. I'm going to be talking today on this subject. I know that lots of people have an in on this topic, personal, clinical. It's quite in the zeitgeist at the moment. So there's been a lot of discussions, I'm sure, in your sort of personal contacts as well. So I'm looking forward to a good discussion at the end, but I'll begin by framing this discussion around identity and psychiatric diagnoses, and particularly thinking about the role of social media in recent decades in driving what I consider to be a bit of a confusion and entwining of these. So although there are many ways in which identity shows up in the psychiatric clinic, I'm going to focus the discussion by introducing a familiar clinical scenario, which is the disorder identified patient who would not attract the diagnosis they seek were they not to seek it. And I'm going to offer something of a framework to think about how we as psychiatrists, and I'm sorry, I will assume I'm talking to psychiatrists, though I understand this topic may be of interest to other clinicians and non-clinicians as well, but how psychiatrists and mental health clinicians might think about negotiating this terrain. And I'm going to leave good time, as Quinton said, for a discussion at the end around how we should think about our simultaneous roles as diagnosers and gatekeepers in this post-stigma era of mental health care. So during this seminar, I'm going to be referring to some examples from a number of diagnoses as identities, namely ASD, autistic spectrum disorder, ADHD, fibromyalgia and physical symptoms, complex PTSD, and if we have time, I'll talk a bit about gender identity dysphoria. But of course, there are other psychiatric diagnoses that are all associated with their own interesting and sometimes problematic identities. And most notably, I don't talk about anorexia. So I apologize for that, but for time constraints, I can't explicitly address every diagnosis. And this seminar, I should also add, is I'm explicitly concerned with the seeking of medicalized self and group identities. And therefore, I'm not going to address those concerned with decoupling their identities from mental health diagnoses, such as you might find in MAD activism. And if you're interested in that topic, this book by Mohammed Rashad from a couple of years ago is really, really comprehensive on that subject. So I'm not going to address that here. But I put this quote up. Hopefully you've had a bit of a time to read it, from Carl Jaspers, as I've been introducing the topic here. And this is just to remind us that, although we have social media now, the expansion of categorical domains in psychiatric diagnosis is quite an old phenomenon. So this is a quote from over 100 years ago. Just as the rings made on the water by raindrops are first small and distinct and then grow larger and larger, swallow each other and vanish, so from time to time in psychiatry there emerge diseases which constantly enlarge themselves until they perish with their own magnitude. So whether this is what we're dealing with here, I'll leave you to think about. So I will begin by introducing the problem under inquiry by describing a case which happened to me a few months back. It's a case that will be familiar to many, I'm sure. So Lana, she was a woman aged 24, and she'd been referred to my general psychiatry outpatient clinic. The GP referral mentioned a number of issues, and these included sort of long-standing anxiety, recent weight loss, and a bad reaction to a recent clinical trial of experimental psychedelic drug. And they also mentioned that querying whether she might have ADHD. And Lana had come prepared to the encounter, without being prompted. She had completed her own self-report symptom scale for ADHD and also got her mother to complete an informant scale. And both documents had been sent over with the referral. So I took a history. Lana was an only child. She'd been quite a high achiever at school until she developed a post-viral fatigue in her late teenage years. And this had sort of delayed her progression to university and normal sort of adult life. But she had recovered from this. She had been able to make good use of a rehabilitation program that was available locally, and she, in a couple of years later than her peers, applied to university, where in the first few years she got on fairly well and had moved out of home, joined social activities and was meeting her deadlines. But then when the pandemic hit and she moved back with her parents, she began to have a return of her sort of brain fog and concentration problems. And around this time she also started spending quite a lot of time on Instagram and TikTok looking for procrastination tips. And she had come across some ADHD accounts and had begun to query whether she might have ADHD. She'd followed some of the tips that were being given on these accounts and had found that they'd helped with her attention. So I'll add that during the assessment, her mental state was unremarkable, and I spoke with her for an hour. She didn't noticeably fidget, interrupt me, or deviate from normal patterns of conversational rapport. And she wasn't drug seeking. She wasn't particularly interested in taking medication. But despite this, she wasn't relieved when I mentioned that I did not think her problem was best understood as ADHD. And instead, she sort of questioned me on all the exact reasons why I didn't endorse the diagnosis. And sort of to my slight discomfort, she had a counter response to every reason that I gave her. So when I suggested that the onset of her cognitive problems had appeared to start with her sort of post-viral fatigue in her late teenage years, she said that in response to this, that girls often mask their symptoms when young, and this is well known and well established. And then when I mentioned that there was a sort of lack of clinical signs during the interview, she responded that she had the inattentive subtype, so she didn't have any hyperactivity. And it sort of became a bit awkward, this back and forth. And I got the impression that this was all coming down to a sense that I had that she had a sort of normally functioning brain, so not a diagnosable brain, and she evidently disagreed. And then the question arose is, doesn't she have more knowledge about her own functioning than I? So this encounter left me a feeling a bit uneasy, and I sort of was suggesting she could request a second opinion, as if I had robbed her of something. I knew that she felt that I was rather obtusely overlooking the Occam's razor to her problems. But for her, ADHD explained a lot of her past difficulties, and wasn't the simple explanation usually the correct one. So it was this encounter, and also talking to colleagues about similar encounters, and that led me to this subject and thinking about this in terms of the seminar and how this has developed. So on some reflection, I sort of came to realize that Lana had already integrated ADHD into her identity. And though she was clearly comfortable questioning my epistemic authority when it came to diagnosing ADHD, it was evidently still important for her to gain external recognition of this in a psychiatrist's office. So she'd come to my NHS clinic not seeking treatment, but to have this identity officially recognised through a diagnosis. And when I wasn't able to endorse her self-diagnosis, this had felt like a threat to her identity. an identity she had committed to and that she valued as a bioillumination, which is a term I'll come back to, but a simple and palatable way to explain a number of ways life had failed to live up to expectations for her. So this seminar's arisen out of my attempt to understand this and similar encounters. And I'm going to begin by talking a little bit about identity, and particularly about how our understanding of the term identity has evolved over recent years, because 70 years ago, identity would really have had only the meaning of sameness or oneness, which is a meaning that we still retain in some of our legal and philosophical language. So the concept of, can you identify this man, meaning is this man the same one as this other person, or Schelling's doctrine of identity, doctrine of mind and body, meaning that mind and body are the same thing. So it's this idea of sameness or oneness. But our more recent understandings of identity as a sort of psychological and socio-political concept have originated and developed through a number of academic discourses. So we have Erikson in 1954. He introduced the identity crisis. And I think this is probably the first time that something like our modern psychopolitical meaning came into influence, and it was quite an influential idea. And I think probably coupled the idea of identity with a sort of idea of crisis and angst. But then we had other strands of academia. So we've got social constructionism. That sometimes dated to 1966, but obviously the ideas behind that go back much further. And then we have in the 70s, Tajfel introduces the term social identity, referring to the sense that people, the sense of self that people derive from belonging to certain social groups. And we see then later in the 70s, obviously we have the idea of identity politics, and the first written reference to identity politics is thought to be from this statement that I've put on the screen here, from the Combahee River Collective Black Feminist Movement. And they say, our politics evolved from a healthy love for ourselves, our sisters, and our community, which allows us to continue our struggle and work. This focusing upon our own oppression is embodied in the concept of identity politics. So I think this becomes quite interesting, because we introduce this idea that appropriate attributes that identity might be formed around in an authentic way are attributes associated with a shared trauma or oppression. And thinking about identity this way makes it, I think, make much more sense that identities might be formed around psychiatric diagnoses. We have some psychiatric diagnoses which have a sort of etiology based in a shared type of trauma, like, for example, complex PTSD or BPD. And what's more, psychiatric oppressions, as sort of broadly conceived, can be invisible. They can be things that potentially people feeling a bit unrooted can sort of attach themselves to in this social media era, which is quite organized around identity. So people who feel like they're sort of lacking in identity in other domains may be able to latch onto sort of a psychiatric diagnosis as an identity, or as a form of shared oppression or trauma. So I'm also going to introduce the idea of psychiatric diagnosis as recognition, and this requires that we talk a little bit about recognition, which is a philosophical concept which was most developed by Hegel in his Phenomenology of Spirit. That's quite a long time ago. He was writing in the early 19th century. And Hegel was not talking about identity, as I said before. It wasn't a concept that they had in those days in that way, but Hegel was talking about freedom. So what does it mean to be a free agent? And he he thought that, you know, you can't just think that you're free, you also have to have your freedom recognized by other agents. And he also explored quite extensively which sort of other agents, you know, have the authority or can meaningfully recognize your freedom. So this, these sort of Hegelian ideas have been translated and applied to identity by thinkers more recently, for example, by Judith Butler and others. So this frames identity as a concept that has to be negotiated with others in society. So you have to have your identity recognized, and that identity needs to be recognized by the right people, the people with authority to do that. And of course, your identity can be misrecognized or not recognized, and this can lead to psychological harms of various sorts, and it can also lead to social harms. So you can be prevented from accessing various things that you might have a right to access had your identity been recognized. But of course, this doesn't mean that we should just automatically recognize everyone's identity, self-identity, because there are various reasons why we might not feel that's appropriate. And some of them come down to clashing worldviews, of course, and others come down to moral concerns. But I'm going to be talking specifically about diagnosis as recognition. And so if we think that in a person that identifies with a psychiatric diagnosis and seeks recognition and having that diagnosis officially given, assigned in a psychiatric clinic, there might be, I suggest, 3 reasons why we may want to not recognize their self-diagnosed identity. So let me just have a sip of water. So the first reason comes back really to the Jaspers quote from the beginning, that if we just recognize everyone's self-identified diagnosis, we essentially allow everyone to self-diagnose, then quite quickly the diagnosis and the recognition of the diagnosis become meaningless. That we have a social role, we're given some epistemic authority, which is necessary for making meaningful diagnoses. And this argument relies on 2 quite unfashionable notions. One is that clinicians might have some sort of tacit knowledge which is uncodifiable, and you need sort of expertise in order and experience in order to gain this tacit knowledge. And the other notion is that the agent themselves or the patient might have some psychological fallibilities. For example, we know well about biases such as confirmation biases and attention biases, which might mean that somebody may believe that they meet, say, a criteria for a diagnosis, but they might be wrong about that. The second reason that we might not want to recognize everyone's self-diagnoses is that diagnosis has, as we know, many competing functions. So diagnosis was not primarily developed as a scaffold for people to build their identities around. Diagnosis has many functions. So we have functions of gatekeeping, rationed, limited services, so that we ensure that the services are going to the people with the greatest need. We sort of try and ensure that, particularly within national health services. But there are other functions. You know, we desire that our diagnoses have scientific validity, so that we can work out, we can understand better these categories of disorder and the biomedical underpinnings of them. And we, you know, if we didn't have, if we allowed the diagnostic system to become a system of self-identification, we would have to replace all of these functions with something else. And the third reason that we might be concerned about just recognizing everyone's self-diagnoses is that we could conceive that there are potential harms to adopting a psychiatric illness identity. So Sur and Weyer, 2 psychologists who were thinking about actually ADHD again, and they were recognizing that people who had been given diagnosis of ADHD or identified as having ADHD had these sorts of structures of their thoughts, which they call response expectancies. So it's a sort of internal nocebo effect. So I have or I am X, therefore Y will now occur. And we can think that in some illness identities, this may be more harmful than in others. So in illness identities that are related to, say, self-harm or, very restricted eating patterns, this could be quite a harmful feature, but it could be, more subtle, that people limit themselves, that unnecessarily, that people feel that they need to take medication which may be inappropriate or have harmful side effects. And obviously there are sort of social harms of over-medicalization, which I'm not going to go into here. So you could respond to all of this and say, shouldn't we just make our criteria more robust, and then we can do very robust criteriological assessments. And obviously that's sort of part of the answer, but I would argue that it's not satisfying either to the patient or the clinician completely. And I really, people may feel subjectively that they fulfill the criteria, whereas you might feel objectively that they don't, so you still end up with some sort of a disagreement. And I think actually for clinicians as well, it's not the most satisfying way to work. And I would suggest that this is because actually, as we feel as clinicians that we do have access to this expertise, which allows us to recognize, a diagnosis in the whole in a person, that we're not just acting as a sort of computer algorithm and ticking boxes, and that there's something else going on in our understanding of diagnosis and our patients that's not fully captured by this. And you could say that that's just us trying to defend our jobs against the robots, but there's some decent defenses of that point of view. I think Joseph Parnass has written quite nicely about it recently. So coming back to how we understand identity today, I'm going to refer to identity meaning something between your individuality, what differentiates you from others, a valorized chosen moral position which orientates your actions. So this may be your posts, likes and follows on social media, which we'll talk a little bit more about, and the relational signals of belongingness, or the hashtags that you might use, which can be associated with particular benefits, including solidarity and expected patterns of discrimination. So this is how I'm going to use the term identity. So I think this has sort of hopefully drawn out a few confusions and conflicts. So the first being, is identity fixed and absolute and enduring personal reality? Because there is something of the older meaning of identity that's come through to the modern understanding of it, that once you have an identity, it's with you for life. And I think this is particularly worrying and relevant in psychiatric diagnostic identities, because actually many people in the public will also conceive of psychiatric diagnoses as being chronic, meaning unrecoverable from, that there's something inherent about your brain or your personality when you get a psychiatric disorder that you can't get better from. And it's quite a common view in the public. So it's one that is worth exploring with patients, particularly when you don't think that's the case. Or is identity an expression of creative freedom? So in that sense, does self-definition provide membership to an identity-based social groups? Or do your external signifiers of membership have to be recognized by others? And if so, which others count? So I think all these questions are really sort of key questions that are going around at the moment, and people have very different sort of views on these. This sort of leads us to the question of, what does it mean to form an identity around a psychiatric diagnosis? What does it mean for the individual, for the clinician, for the NHS, for society? But I'm going to spend the rest of the time that I have thinking a little bit about social media and how illness identities develop. So to start with, why possibly would anyone want to have a illness identity around a psychiatric diagnosis? I think a lot has been written, particularly actually in the ASD community, about bioillumination. So Ballant of the Ballant Group fame, over half a century ago, he pointed out that for the patient as well as the psychiatrist, a diagnosis transforms an agglomeration of complaints and symptoms that might be unclear, unconnected, and mysterious into an entity that is more understandable, an organized illness, which provides someone a framework to cultivate and refine their self-story. And as I mentioned, this has been picked up and recognized by many people actually who have received diagnoses and found them a relief. So this from a paper about ASD identity called "I'm a Normal Autistic Person, Not an Abnormal Neurotypical," I think summarizes this bioillumination role quite well. So the diagnostic label carried medical and existential relevance. It provided participants an explanation for their atypicality and concurrently offered a framework with which to reinterpret and develop their self-concept. Behaviors and challenges of past and present were attributed new meaning and appreciation through the lens of ASD. Accordingly, the moral implications of these behaviors and challenges were re-evaluated. And this has been described in a number of illness identities. So diagnosis is undoubtedly a positive experience for many, and there are lots of examples of these sorts of redemption stories online. However, we know that the explanatory value of diagnosis is not just applied to past difficulties, it can also orientate present and future actions, which we've spoken a little bit about. So I think it's really interesting to think about how to navigate this domain clinically, because obviously knowing that illness identities are really helpful for some but may be harmful for others leads us to really think about how we can understand who these categories might apply to, and how we can sort of get to know that, and what might be the impact of us agreeing with or withholding a diagnosis which is sought. So at the top here, Mercer in 1966 described that an individual can be on a trajectory of identity formation and revision between exploration and commitment to specific identities. So I suggest that this is quite important to think about, because for those in the exploratory stages, confirming an ill-fitting diagnosis might act as a foreclosure to self-exploration and further understanding. But for those in the later stages of commitment to an illness identity, a lack of confirmation is more likely to be experienced as a painful loss. And I think it's worth being aware that, whatever stage in the exploration commitment trajectory an individual consults a psychiatrist, the consultation is likely to be charged with some significance. It's a crossroads at which an identity is confirmed to be bound with a psychiatric diagnosis, perhaps irreversibly, or perhaps where a different exploratory path is embarked on. Looking at the lower part of the screen, these are dynamics that have been described in group identity. And the way that the patient perceives the group identity dynamics of the particular illness identity is also important. So Haslam, who has written quite a lot about psychology of health, and particularly in terms of sort of social group identity and health, has outlined 3 conditions of a group which impact on the dynamics of the group identity. So the permeability of the group boundaries is quite important. So that is whether or not the group members feel that it's possible to freely exit and enter the group. And so often, as I was saying, mental health identities are perceived as being quite impermeable due to a common conflation of mental health conditions, chronicity and unrecoverability. These types of perceptions may be more or less correct, depending on the condition, of course. But other conditions of the group identity dynamics include the desirability of group membership, so how positive the identity is, and also the stability or the legitimacy of the group relations. So a group identity might be unstable, for example, when there's a large rapid increase in the number of people identifying with a diagnosis over time, or for example when the identity is associated with a contested illness and the membership criteria constantly being redrawn. So this is important because it's thought to influence how people respond when there's a threat to the group identity. And that threat might be to an individual's membership of a group. For example, if someone was told, who identified with a diagnosis, was told that they didn't fulfill the criteria for that diagnosis, how might they respond? Or other threats might be things like a sort of stigma or loss of prestige, or some other threat to the identity. And Haslam writes that if the identity is perceived as being permeable, in that the patient can leave the group, then they will tend to leave the group if there's a threat to their identity as a member of that group. But if the group is seen as being impermeable, there are two main responses. One is sort of creative redrawing or rebranding of the group identity. And this, I think, can be seen, for example, in the sort of neurodivergent rebranding or redrawing of ASD. And the other response, where the group is seen as being more unstable and impermeable, there's more of a social competition response. And this involves members of the group trying to change the sort of social circumstances around their diagnosis. So I would suggest that perhaps the ME community is a little bit more like this. It's sort of a more contested illness, seen as being a bit more unstable, and therefore the response to a threat to the group identity is more likely to be social competition, trying to change the way that they are able to move through the world and services. So in her 2002 paper, which is called Self-Help Literature in the Making of an Illness Identity, The Case for Fibromyalgia Syndrome, the sociologist Kristen Barker draws on pre-existing literatures around illness experience and collective identity formation to examine the evolution of fibromyalgia as a collective illness identity. And her study, which was situated in the late 90s and early 2000s, is concerned with self-help books and internet forums such as WebMD. And she suggests that these documents and posts act as identity artifacts, which are cognitive resources for collective identity formation. And she describes in this paper how in the multiplying and over-inclusive descriptions, or increasingly inclusive descriptions of fibromyalgia, women could recognize their own suffering. They could also find solidarity, and they could begin to explain multiple facets of their experience in the light of fibromyalgia. She also mentions in her conclusion that while illness affiliation offers FMS sufferers general support and encouragement, the new subjectivities that it propagates can significantly accelerate the already strong trend towards medicalization. Today, TikTok has overtaken message boards and self-help books as the most potent identity artifacts. And like on the fibromyalgia message boards of the 1990s, the TikTok illness communities both endorse and expand a criteriological approach to diagnosis. And the format's particularly well suited to suggesting symptoms that people may use to identify pathology in themselves. And it's not a leap to speculate that the algorithms that favoring these become increasingly inclusive. So the more people relate to a post about a feasible symptom, the more the post will be watched and shared to others. And the symptoms themselves, if you look on TikTok, are often medically inaccurate or just absurd. So for example, the doom drawer, which is, you might have been known in previous generations of the junk drawer, or sometimes the man space, or it's just the drawer where you put things in your home which don't have to live. This has been rebranded as the doom drawer, which is apparently a clear sign that you have ADHD, according to TikTok. And I'll show you another example of this sort of absurd, slightly absurd. As you can see, wishing that you had trauma is apparently a sign that you've had trauma, potentially could have complex PTSD. And you would think that this is sort of ironic, but if you look through the comments to this video, there's about 30,000 comments, and people are generally relating to this, and taking it quite seriously that this may be an accurate sign. And you also, Barker, in her study of fibromyalgia back a couple of decades ago, she also noted that illness identity communities often have sort of coaching of their members in how to be assertive in order to access specific treatments. And this also continues today. So there's quite a lot of videos from a range of lay mental health experts in quotation marks that produce videos about what to say to your doctor, and sometimes even videos to show to your doctor that to convince them that you might have the condition. And often you find that if you don't clearly meet the diagnostic criteria, this isn't really a problem either. There's lots of trending videos that give you explanations about why you might, why your symptoms might have been masked by other sort of personal attributes. So this is so these sorts of videos have obviously far more views than most sort of public health communication or mental health communication, and there's this idea that new epistemologies are created, that these illness communities are developing their own ways to define and think about these disorders and even the underlying science behind them. And often these develop in such a way that they can't really be realigned with like the epistemology that we have underlying medical sciences. So inevitably will lead to some conflict. I think that's sort of inevitable. I think this is a really interesting paper. I won't spend too much time on this, but what makes a diagnosis identitogenic? So some diagnoses attract this sort of increasing attraction as an identity. And Griffiths and Stein did this study on Tumblr posts, which is a message board where people might post, for example, I'm feeling depressed today, or I think I've got PTSD. And what they did is they looked at all the posts that mentioned any of these diagnoses in them, and they looked at two things. They looked firstly at how many responses that post got in terms of likes and encouraging messages and follows and things like that from the rest of the community, who generally are strangers to that person, so they're not members of the social group, but other people just using the online forums. And then they looked at the relationship between getting those responses and how likely that person was to post again. And we know that identity is very strongly formed when people sort of publicly declare their identity, and that can be sort of in a written way. So posting on a message forum and then having that approved increased the likelihood that you were going to post again. And this sort of affirmation cycle is probably quite important in how people develop their diagnostic identities. But the problem is that this sort of recognition that you're getting is completely blind. So when people are responding to you online, they're not responding to you as a person saying, you know, like, well, maybe it's anxiety, maybe this is that. They're normally just responding to your post, and they're normally sort of affirming it. And this is particularly true in the steeper lines here that you see. So you can see at the top we have anorexia, autism, and bipolar affective, BPD. And I think these are some of the diagnoses that we have seen this impact, particularly with the increasing identities around them. They haven't looked at ADHD, but I suspect that would be quite a steep line as well. I was going to talk about gender a little bit, but I think we sort of are coming to the end of time, and I think it would be really interesting to hear some responses from this. Yeah, I think maybe over to Quintin, and I was going to suggest how we should respond to this, but I think it would just be more interesting to have a bit of a discussion about what people feel about all of this and their personal experiences, and if you are able to suggest how we might think about responding to these challenges. That would be great. So I'm going to stop sharing now. Thank you.
Thank you very much, Chloe. That was really interesting. So I'm just going to invite any responses from from those present today, any reflections, thoughts, questions, experiences. So please do come forward. And Elisa, just tip me off if somebody wants to speak, and I haven't noticed it.
Yeah, I mean, I think people should feel free to just unmute themselves and put themselves on video if they like to just join in. Yeah. Or if you feel a bit more shy, you can write it in the chat and I'll relay that to Quentin. Yeah.
I have a comment, please.
Please
Thanks
do.
so much. Thank you. Thanks so much, Chloe. I've read a lot about some of the things that you've presented. I've been in school to be a therapist in the United States, but then I also have a biology and sociology degree. And one of the things that I studied that I wondered if you were curious about or had researched what is called a unit cohesion, which happens in the military when you talk about trauma and how soldiers will engage in cohesion in order to protect themselves, and they'll start engaging in behaviors and identities. But then when they're out of the military, they'll take that out into the world and become defensive, as you state. And I just see parallels to that in your research, where I think it would be an add-on possibly.
Yeah, thanks, Chris. You know, that's not something I've come across or been reading about. So yeah, thanks for bringing that up. And if there's anything that you wanted to recommend to start the reading off, then I'd gratefully to get that recommendation.
Could I send that back through the person who sent out the link to this to get to you?
Yeah, that would be grand. Yeah, thank you.
Okay, thanks.
Thank you very much. There's a comment from Helen Holmes. This may seem very obvious, but is there not a huge move towards identities rather than identity? Any reflections on that, Chloe?
Yeah, I can reflect a bit on that, and I think it's yeah, I think that our understanding, or most people's understanding, is that you'd have multiple identities in different domains, and so it's sort of more almost like your character traits in a sense, but I think that the ways that different identities interact is obviously quite interesting, and there are some things that identity is sort of more authentically drawn around than others. So I haven't talked at all about ethnicity. I recognise in this seminar, and actually that's partly because you know, much of the research I was looking at was based in a sort of higher income Western group, but I think, you know, how all these factors play out is going to be there's going to be many different types of identity that are influencing how people read their life experiences and how they interpret their life experiences in relation to psychiatric illnesses, and I think that's yeah, definitely worth highlighting. Is that sort of what you were referring to, Helen?
Yeah, sorry, a bit hesitant to speak. Yeah, no, I think it was what I was thinking about. I was just wondering, you know, why, I mean, maybe it's because there's more information, we're better informed, why there is this kind of massive move, especially I suppose in sexual identities and gender identities, why there's this huge move, you know, it's like a kind of volcano of nuanced identities. And I'm just wondering why, you know, like what you may think that you know, what's led to that.
Yeah, I mean, I do have some thoughts about this, which I couldn't possibly, you know, evidence really, but my instinct is that there's, you know, there's something to do with both the loss of community that people are experiencing in the Western world, particularly in sort of younger generations, and a sort of a feeling that they are sort of cut adrift away in a way. They don't have necessarily you know, a clear job or sort of family identity in the same way that possibly previous generations had access to. I think there's lots of factors behind that, economic factors and socio-political factors. So I think that's part of it, and I think people are trying to sort of root themselves by finding these other identity groups to be part of. It's obviously much more. It's how people talk nowadays, so that obviously influences things as well. And I think that comes through, academia and obviously politics as well. But I think social media does have a role because on social media you basically you're sorted by algorithms into identity bubbles. So you sort of what you identify as on social media will then be reinforced by the algorithms, and I think this also has impacts, and I think it's just convenient for social media to do this. It's convenient for advertisers as well, and you can be cynical or even political parties to organize people into identity groups in this way. So I think there's a lot of different forces at once which have gone into this, but as I said, that's all speculation and possibly haven't looked into a lot of the evidence behind that.
Maybe I could just say one more thing. I was just thinking about whether it's a benefit or not, to like have these kind of multiple identities that are more out in the open, or whether it fragments and has overwhelmed with too much choice, almost, rather than like a personal identity of a sense of self, of who I am, and whether actually that's answerable at any point.
Yeah, I think it's complicated probably. The stuff about gender I was gonna talk about was a little bit thinking about these issues, because in gender identities there's sort of obviously different movements, but there's a movement which so sort of the non-binary trans movement is concerned about the sort of pathologization, self-pathologization that comes with a trans identity. So because having a trans identity has been linked to having gender identity dysphoria, and also has been linked to this sort of narrative of feeling like you're born in the wrong body, and therefore sort of disliking your own body, then there's a feeling amongst some members of the trans community that this leads people to suffer in a way that they don't necessarily need to suffer if there was a sort of a more rich and diverse number of genders available to people, and the decoupling of feeling like you're in the wrong body and dysphoria with the trans identity. So the non-binary trans movement is very much interested in people being able to define their gender without hating their body, and therefore if you want to have transitional surgery, then that's a sort of authentic choice that you're making, rather than an inevitability from having that trans identity. So I think there are positives and I think negatives to all of this stuff, and it gets a bit it's interesting to think about it, and I think particularly when it is linked to diagnosis and interventions, medical interventions, whether they be pharmaceutical, psychiatric pharmaceuticals, or in the case of trans healthcare, obviously surgery and things like that. So it then becomes very important to think about all of the harms and benefits of the identity and also of the diagnosis, and whether the two need to be linked or not. And I think what's come out of quite a lot of the queer literature on this has been some understanding that these things should be more transparent, that identity and diagnosis should be decoupled, and that's obviously a movement that's gone on in trans healthcare. So to try and essentially decouple having a trans identity from having gender identity dysphoria, and so those things can be decoupled. So then if you want to access a diagnosis, you have a discussion with your doctor about what that diagnosis means, and whether you may want it or not, whether it helps you achieve your aims or not. So I think it's there's been a lot of thought in that area on all of this stuff, but it is quite complicated and sticky.
Oh, it's amazingly complicated. I'm just in awe of you being able to be so articulate as I stumble through my words. So thanks. Thanks.
Thank you. Yeah.
Thank you. Any more suggestions or comments, thoughts at this point?
There's a hand from Peter. If you want to unmute yourself, Peter, please join in.
That's it. That's done it. Yes, I'm picking up your Dr. Saunders, your comment about wondering how we should respond. I'm not a psychiatrist. I'm a psychoanalytic psychotherapist in private practice, and the impression that I get is that quite often psychiatrists do respond by not gratifying the patient. It's not uncommon to have a patient come in to psychotherapy who's very much aggrieved and has tried very, very hard to get a diagnosis. I mean, really hard, and has failed to do so. And it's despite deploying great ingenuity to be diagnosed with something or other. And the response of psychiatrists seems to have been quite wary and cautious about these patients, and not being quite reluctant really to gratify the patient and fit them into a sort of a pattern. I'm thinking, you know, you're talking about people, as you say, who aren't seeking treatment. People aren't seeking treatment. They're seeking medical confirmation of an identity. And I thought there was a sort of clue there in something you said in passing as you were making your presentation, which is that patients of this type come to you as psychiatrists or to a psychotherapist because life fails to live up to expectations. And my thought about it is it's going to how do we respond? But I think how a patient wants us to respond is by agreeing with the patient, you know. And if we don't, well then, you know, we're sort of on the wrong side of things, and we're a kind of opponent. But it seems to me that there's something in all of this that's to do with how unpalatable it is to suffer. You know, to have any kind of, you know, conflict or difficulty that you might want to have to wrestle with, of life failing to live up to expectations and being disappointing and so forth. And there's something about getting the diagnosis that allows a kind of pathway into a sort of life where you're kind of eased through life in a certain way, perhaps you could say, by virtue of the fact that you have this certain diagnosis. So as to how we respond, I suppose the only thing that comes to mind is to say, well, is to try to invite the patient to think about some of this. But I think it's thinking about it is exactly what they do. You know, on the whole, patients really are very reluctant to do, quite phobic about it in a sense.
Yeah, thank you for that, Peter. I mean, I would agree with all of that, and I think that I think we will always get it wrong. I think that, you know, there's some borderline cases where you know, we may not think, you know, the person quite fulfills the criteria, but we may also think that it would be helpful for them to have that ability to medicalize an aspect of their suffering. And you know, it's unlikely to cause that many harms. And we may, you know, I think often psychiatrists do assign diagnoses in those sorts of situations. I think particularly we see that in ASD or ADHD, where, you know, the diagnosis itself is unlikely to be particularly harmful or you know, require a lot of input from services and so you know, I think that we do that, but I think there's also something, you know, psychologically in a certain type of person who reaches to that medicalization and over others, and I think that's partly cultural, and it's partly to do with the way that they might you know, their flexibility of cognition, and the types of explanations that they tend to go towards for difficulties. So I think there is overlap between, say, somaticizing patients and patients who seek psychiatric diagnoses as well. Actually, I think there's been some at least some anecdotal evidence that a lot of somaticizing patients also seek ADHD diagnoses and various other things, and that, you know, there may be some genuine phenomenological overlap there, but yeah, it's I think when you come up with a patient who just is very clearly that's the answer that they want, and that would really be of benefit to them, I've sort of come to the opinion that unless there are you know, harms associated with that, and as long as you feel that you can help them navigate that in a helpful way, then it's usually okay to assign the diagnosis. Yeah. Yeah.
Thanks, Chloe. We've got a couple of comments, and then Ella's got a hand up, so perhaps I can read out the comments. Actually, some of them may invite a response from you as well. So Naomi Fisher wrote, I wondered if you have any thoughts on the emergence of affirmative diagnostic services for autism and ADHD, and if anyone's writing about this. Perhaps you've already partly answered this. So the idea of an affirmative diagnostic service.
Yeah, I've sort of just already answered this a bit, actually. I wrote it. Can you hear me?
Yeah.
Yes, yeah, you wrote it before, because it's something I've noticed myself, that more people who come are asking me if I provide affirmative diagnoses rather than simply a diagnosis. And there are people who are specifically advertising themselves as affirmative diagnoses. And I'm interested, as someone who researches autism, because I'm wondering what that means for us as researchers. And you've just said, Chloe, that I've been the same, that if you have people who come who are really, really keen to have a diagnosis and they really feel it's very important, then I often err on the side of giving it. But then I wonder, what am I doing to the to that group? What am I doing to the future of research in this category?
Yeah, I think that's one of the dilemmas we have, isn't it? And one of the sort of shared responsibilities we have to balance as clinicians. That, and I think that attempts to place these things on spectrums is quite helpful. So I've not heard of the idea of affirmative diagnosis, but I think if there's a move towards a concept that you have maybe a clinical diagnosis and an affirmative diagnosis as two separate things, then you could possibly affirm people's concerns about their character traits, or their neurodiversity in a helpful way, whilst also maintaining the validity of the clinical cohort. So yeah, that's an interesting idea, but I think it would require a lot of clarity around it, what was being done and why. And I think there's a lot of inconsistency at the moment in terms of how clinicians are approaching this.
Thank you very much. I'll very briefly reflect on that, actually, as somebody who works in neurodevelopmental services. So I think this is a very tricky question. I'm just thinking back on occasions where I think actually I've got a diagnosis wrong. So I've given a diagnosis where I don't think actually it was entirely justified, perhaps in retrospect, and also the other way around. But the notion that you can get a diagnosis wrong is an interesting one, because of course it raises the question, well, actually what counts as a correct diagnosis? And I suppose I'm trying to triangulate a bit here, because it's clear that some people are very motivated to receive a particular type of diagnosis. But I think if we don't have some grounding in what the construct is to justify the assignation of a diagnosis, then actually ultimately will undermine our own epistemic authority, quite apart from broader society doing it for us. So I want to hold on to the idea actually that it is difficult. There are problems posed by the dimensionality of traits and symptoms, and but actually we should retain the idea of a kind of goodness of fit of a construct, that a construct fits somebody in a way that has explanatory power and is helpful to them. So I'm going to sort of, you know, just really, you know, try to raise the standard, if you like, for that notion. So yeah, it's the other reflection actually is thinking about, so I've worked both in the NHS and in private practice. And actually, I think if you keep knocking on enough doors on Wimpole Street, you can basically get whatever diagnosis you like. I do think diagnoses are ultimately, to some extent, you know, they're purchasable if people try hard enough, which is of course not correct, following on from what I've just said. But I do think there's something, I think that is a truth. I think we do. The other thing worth reflecting on, and again, I won't speak for too long on this, is actually the consequences of misdiagnosis when you apply a construct to somebody, which actually not only does it not fit, but it misses some important aspects or difficulties that they have. And it can set them on a pathway where cumulatively it means that they might miss out on things that could be helpful to them. Because they understand their difficulties differently. Other people around them understand their difficulties. Anyway, just a few sort of reflections and thoughts there. Chloe, I don't know if you've got any thoughts on that before moving on to our next comment from Kate Spencer-Brand, then we'll go to Ella as well, who's patiently kept her hand up. Any thoughts at the moment, Chloe? Just
Yeah, I'm happy to go to the next comment.
okay, so Kate Spencer-Brand says, I think that when someone comes to mental health service for a specific diagnosis, the key issue is to validate their difficulties and unmet needs where they exist. Make it clear that the person and their problems are not being rejected, even if their specific suggestion of a given diagnosis itself is being rejected. So I think, Kate, you've also found your own way of saying very clearly probably what I just said as well. Any thoughts on that, Chloe? Any response to Kate?
Yeah, I mean, I have tried this before. It's actually led to a complaint on one occasion. So I think it's one of those things that's perhaps a bit easier to do in a psychodynamic setting or a psychoanalytic setting, psychotherapeutic. But yeah, I agree. That's what we should be aiming to do, definitely. And I think we just have to accept that for some patients that won't be satisfactory, that they've set themselves on wanting a particular answer. But yeah. No, definitely, I agree with that principle.
Hi, sorry, I just wanted to add that I think it's particularly like in the TikTok you showed about trauma. I think with that, there's a difficulty that in society, I think some types of trauma get recognised as trauma, such as obviously sexual abuse, whereas other things that are more seen as more kind of subtle, like emotional abuse or neglect, don't get recognised in the same way. And I think potentially people that are in that situation where they're sort of wishing they had experienced trauma, if you can say in that clinical setting where someone's come to you and sort of is maybe wanting a BPD diagnosis, I suspect that that's what that's about. It's about opening up the conversation to what they might have experienced that's actually been very negative, and talking about that and exploring it, because I think there's this pressure to have a specific loud story to tell, and then that validates the pain they're in. And actually, if you can take the encounter to explore things they might be dismissing and not taking seriously enough, then that can open up a whole range of options, which if you can address the pain behind the reason for coming for the diagnosis, I think in some sense you can diffuse the need for that specific diagnosis, but it is about having the time to explore. And obviously mental health services, you know, don't have time. There's so much pressure. It's so hard to even get past a GP. So there is, I think, a conflict between the practical barriers and setup of the NHS that just makes it really hard for people who have things they don't even know how to express. And so you get this pattern set up of people trying to get help for problems they don't even necessarily have words for. The GP doesn't understand, people don't understand, and by the time people get through to say a consultant psychiatrist, there's already so much negative feeling built up around accessing help that all of that has to be dealt with before you can even get to the point of saying, I do agree with your diagnosis or I don't agree with your diagnosis. So it's kind of taking it slowly and not saying this first encounter is going to come out with the outcome of I agree with your diagnosis or I don't, but saying in the first instance, can we just step back and just explore the difficulties in your life broadly and in context and understanding their perspective. And I think if the services can allow it, can allow a conversation like that to develop and a relationship to develop, then that would sort of diffuse some of these issues. But obviously, you know, everyone's time limited. So, but that's kind of, yeah, my thoughts on everything. But thank you for everything you've said.
Yeah, no, thank you for those words as well, Kate. Yeah, really, really wise words, good perspective.
Thank you. And I think, so Fiona's a comment, but I think I'm going to switch to Ella and then come to Fiona's comment. I can't remember the order in which they came in, but Ella, your hand has been patiently been up for a very long time. So do you want to contribute now to Fiona's comment?
Thank you, Chloe. That was a really interesting talk and it gave me lots to think about. But I came to this from the concerns that I had around critical race theory being taught in schools and racial identity being taught in schools and people self-identifying as racial oppressors or self-identifying as racially oppressed. I think the quote that you put up about focusing on your own oppression as being embodied in the concept of identity politics is quite relevant. You know, at the moment, because of all the identity politics around race. I won't get into religion, that's another aspect to it as well. But I'm not sure I really have a question for you, just lots and lots of thoughts to bring up really. But I wondered if you'd heard about the teaching of whiteness as a mental illness. Whether you've heard about the teaching of post-traumatic slave syndrome as being a mental condition, race-based traumatic stress. Obviously, these are not medical diagnoses, but these are being taught in universities and colleges as mental conditions, that whiteness is a sort of mental condition.
Yeah, I actually I don't know much about critical race theory. It sort of doesn't surprise me what you say about that being taught in universities under critical race theory, because I think that there is this sort of general adoption of the language of psychiatry across lots of domains of thought, and I do think that's problematic because people obviously are confused by that, and they, you know, how can people know what is a mental disorder and what is, you know, being compared to a mental disorder in a sort of metaphorical way.
I'm going to read Fiona's comment now. I think this follows on from the issue about perhaps having a very low threshold for assigning diagnosis. This can definitely be an issue for research. I'm aware of participants who've told us they have a diagnosis of autism, but who really don't seem to fit the criteria on the basis of research assessment, sometimes seeming to have evidence of another diagnosis, such as bipolar disorder. Ultimately, we need to do thorough research diagnostic assessments and exclude participants' data when appropriate. So that's a research perspective, which I think is obviously important. So any thoughts on that, Chloe? Any response to that?
I think Fiona's unmuted. I don't know if you wanted to expand on your comment, Fiona.
Yeah, I was just going to say it's definitely something that we've come across, and sometimes it does seem to be people who've been diagnosed as an adult and seem to have gone to multiple different professionals till they've got a diagnosis, so that, you know, it's a sort of hint that there's maybe been that sort of diagnosis seeking behaviour, and we have to be a little bit uncertain about that. But I think it does mean that any research that's based on people sort of self-reported diagnoses and us just taking that at face value can become, you know, maybe will become increasingly problematic, and especially because we know a lot of the tools that we sometimes use, like the AQ to, you know, as a measure of autistic traits, we know that picks up lots of other things like anxiety and so on. So I think, you know, I think it can really sort of cause problems for research. So I think it's something that, you know, we really need to think about in that context. If it's okay, I just wanted to make a very other quick comment, which was about I was really interested in what you said towards the beginning of the discussion about why this is happening. And I really, it sort of chimes with probably the way that I was thinking about the sort of loss of community and the fact that we increasingly have younger generations that feel a bit disconnected seemingly from their own communities, that don't necessarily have a solid social network, you know, work and so on. And it sort of reminded me, but I think it sort of, this is also reflected in the sort of lack of social explanations for a lot of our problems. And the fact that we then sort of push those problems into the individual and sort of, you know, medical explanations, and therefore medical individual solutions as well. It reminds me of a meme that was doing around ages ago, which was sort of employees saying, we're really stressed at work because we're not getting paid enough and we're short staffed, so everyone's having to cover other people's jobs and we're really, really stressed. And then employers saying, here, have some well-being or mindfulness sessions, you know, and completely missing the mark. So it just seems that, you know, and that's being pushed, you know, in many places, and probably many of our own employers do these sorts of things, you know. So there's that failure to recognise and discuss a lot of these problems as being social and related to the structure of our society. Therefore, it's all interpreted and experienced as individual and medicalised. So obviously that's not a problem you solve in necessarily in a sort of individual therapeutic setting, but there's obviously a much wider discussion to be had about how we understand some of these problems. So I just wanted to chip that in as well.
Yeah, thanks for that, Fiona. Yeah, both those perspectives I slightly neglected in the talk for time reasons, but yeah, I'm very much in agreement with both the concerns around research and the direction that research may have to go in order to sort of preserve the validity of the studies that are being undertaken, but also the sort of sociological utility of medicalization and potential other powers and forces that favour that explanation. So yeah, thank you.
Thank you. George, I see your hand is raised. I hope I haven't missed something. Please do speak, George.
Can you hear me okay?
We can, yeah.
Yeah. Thank you very much, Chloe. That's a very interesting talk, and it's obviously a very complex problem. My question is, what do we know about the longer-term outcomes of people who present wanting a validation of a diagnosis where the validation is not forthcoming, or those where they receive the diagnosis, although it may be empirically questionable? Do we have information? I mean, for example, I remember Ian Hacking talking about the looping process for people with multiple personality. And I just wondered what happens 5 years or 10 years later. I mean, I appreciate the difficulty in following up people who may be, you know, very resentful of the kind of reception they've received by mental health services. But has there been any follow-up, longer-term follow-up, 5 years, 10 years, and especially with interviewing people about their experience and about what it has meant to them and what kind of changes there have been and what their attitude is to it 5 or 10 years later?
Yeah, thanks for that, George. I think it's probably quite condition specific, actually. And time and place and culture specific, and I think that the short answer to your question is I don't think there's much, or at least I haven't come across much research on this. I do know of a bit of research in the area of functional or physical symptom diagnoses, so things like fibromyalgia and chronic fatigue syndrome, I know that there is a bit of qualitative work on that, and there's also a paper which I came across about young people and the impact of sort of giving CAMS diagnoses. I think CAMS has done a bit more work on this, but that's quite specific to that context as well. So I don't know if there's anything with longer follow-ups as well for those young people. I know there's just qualitative work about the impact of diagnosis on young people, but if anyone knows of anything that might be more relevant to George's question, then feel free to chip in.
I don't. Oh, is there a response to George? I hope I haven't missed anything. Elisa, if I have, please do flag up. It's a very interesting research question, actually. Of course, what motivates the seeking of a particular diagnosis and what happens to a person should they not get a diagnosis, but actually also what happens to people when they do receive a diagnosis, which actually doesn't particularly capture their difficulties well. So I think it's a very interesting area of research and possibly under researched. I just wanted to share a reflection on what you're saying, Chloe. And I think it's been touched on at various points, but it's actually the question of this is clearly a very complex set of dynamics going on culturally, socially surrounding diagnosis. But it does seem to me that there are different tensions in play. And one of the tensions is essentially the role of diagnosis as articulating or capturing something real about a person, which brings it to light and helps explain it. So something that was hidden, but which the diagnosis, sort of bioillumination concept, versus a different attention with a different idea, which is perhaps the idea that diagnosis is perhaps quite a thin exercise and maybe influenced by social constructivist or anti-psychiatrist or anti-medical views, but that actually diagnoses are constructs which are not particularly, or in many cases, not very grounded at all in what human beings really are, and they reflect other social labeling forces or other sorts of social forces. So because it seems that both notions somehow are in tension or in play at once. The idea that you can campaign for a diagnosis because of its explanatory power, and perhaps it gives access to identity and so on. But at the same time, that people can move through diagnoses. They can wear a diagnosis and then move on to another one, perhaps. I don't know if you sort of sense that tension, or you think that that's there in what you've been reading about, Chloe, in your own experience.
Yeah, thank you, Quentin. I mean, I think that does cut to me the core of the frustration, which is that the ontology of what people believe a diagnosis is. And I think that because we've had quite a long era of sort of reductionism and the idea that you have a brain abnormality when you have a psychiatric disorder, that's what generally is believed. And I think most people believe that when they get a psychiatric disorder, that is them for life. Like there's something intrinsically inherent about their brain or their genetic makeup or that has caused that illness in them. And that is obviously not how we understand psychiatric diagnoses. That's not how that's not the case to larger or lesser extent. But I think that is problematic because for lots of reasons, that when people are receiving a diagnosis, they're not actually they're understanding it as something, I think, quite sort of real and impermeable, coming back to these group identity dynamics. And I think that's one way that we could challenge, we could sort of try to move this in a different direction, is to challenge that idea. but that I think would be very unfashionable in lots of areas as well, because lots of people are vested in the sort of brain disorder concept of psychiatric diagnoses. So yeah, but I think that to me is sort of the nub of the frustration, is just is this a sort of misinterpretation of what that diagnosis is and means to a person. But, yeah.
Thank you, Chloe. So culture and history to some extent have come up, and actually I think I'd also like to reflect on their importance, and perhaps suggest that there's some very interesting questions to understand about how the social understanding or reception or practices surrounding a particular diagnosis may or may not have changed over the past decades for older diagnoses. But actually also cross-culturally. I think in medical anthropology, I think it's a very important resource for thinking about human practices surrounding the articulation, understanding of distress. And so there's a social anthropologist, medical anthropologist called Mark Nichter, who proposed this concept of idioms of distress when talking about spirit possession in South Indian women in papers in the 90s, and it became quite an important concept. So I think the notion that our diagnoses are idioms of distress, and particularly then enlarging it to the point that was also made, I think possibly by Ella as well and yourself, Chloe, about atomization and the kind of social context, the social conditions under which people live now, and the role of diagnosing under those circumstances, I think is very important. It's medicalization as a way of a kind of authoritative way of articulating distress. So that's just a reflection, really. So Chloe, we're nearing the end. It's been an extremely interesting and fruitful presentation, and indeed discussion. We're on the sort of home stretch now. I hope I haven't missed any comments or questions that anybody wanted to make, but just invite you to make some concluding, any conclusions that you wish to make, or concluding thoughts for us.
Yeah, well, thank you, Quentin. Yeah, I'll wrap up because it's just gone 8:30. But I just wanted to say thank you, everyone, for engaging in this discussion. It's been really interesting for me as well, and I'm sort of making this a bit of a work in progress. So hopefully I could use some of your ideas towards writing about this a bit further. So yeah, thank you to the Maudsley Philosophy Group for the opportunity to give this talk today, and for all of you for your comments. And yeah, thank you, Quentin.
Great. Well, I think if we can virtually extend our sort of a round of thanks and applause to Chloe, if you know how to use the icons or not, I'm just going to clap like that. So thank you so much, Chloe. That was really, really interesting and stimulating. Brilliant discussion as well. So thank you so much to all of those attending for your contributions. It's very rich and productive. We're very grateful to all of you, actually, for your contributions and for attending. So we will conclude today. So I'll wish everybody on behalf of the Maudsley Philosophy Group a good evening. Thank you for joining us, and thank you once again to Chloe. Okay, take care now.